There are times in your life when there are literally some revolutions that are happening. And I think what we're looking at in this year is a revolution in medicine, particularly cardiovascular medicine. And I can say this now with some degree of authority that the methodologies, the traditional care, the treatments, and even some of the surgeries that we've been doing for the last 25 to 30 years in cardiovascular disease are misdirected. They're obsolete, and they're very limited in their scope. What I hope to do in my brief time with you today is take you into the next generation of how to prevent and treat cardiovascular disease. So let's start with some very basic concepts in cardiovascular medicine. We're going to go through this very slowly, very methodically, so that everyone understands exactly what this means to you as a consumer, but also what you can do as a patient to try to educate not just yourself, your family, and your friends, but also educate your physician about what you need to understand and what he needs to do to take good care of you. Now, I'm going to show you a picture first of what your heart looks like on what's called a CT scan. It literally shows everything inside the chest cavity. And we can take this and magnify it many-fold and start to actually look at the arteries in your heart, see how the heart functions, how the valves look, and get huge amounts of information without being invasive. So non-invasive treatment and diagnosis now is very possible in cardiovascular disease. Many of you may recognize this particular photo, but this is what's going on inside your arteries and inside your heart. This is the Icelandic volcano that erupted. So there is now fire and inflammation within your heart and your arteries. And this is the new concept in cardiovascular disease, is how to quell the inflammation. What's causing the inflammation? Rather than saying, well, you've got a high cholesterol, let's put you on a statin and get it down and you'll be okay. That's the wrong message. The message should be, you have inflamed arteries and an inflamed heart. And there's 400 reasons for that. Not one or two. So let's see if we can figure out what it is in you that's making your heart and your arteries inflamed. And go back to the beginning. Ask the question, why? Not just, here's a prescription to go take to fix what I found in my 1-minute visit with you. This is a huge problem in this country. Just high blood pressure alone is 74 million patients. Those who have heart disease are 17 million. We have 7 million people that have strokes. That's 98 million U.S. patients that have heart disease. The cost for that is $70 to $80 billion a year. And I can tell you, if we did the right thing with preventive cardiology, we could reduce the frequency by 70 to 80%, and that cost would drop by an equivalent amount. Every 1 in every 3 deaths in this country is a cardiovascular death. So it's 2,200 deaths per day just from heart disease and stroke. And we could reduce that, if we did the right things, to 70 to 80% less. Now, if you live where I do, which is Nashville, Tennessee, the southeast, we have what is called the stroke belt, the heart belt, the everything belt, and literally this belt as well. And so if you look at this, you see those areas that have the kind of the gray color. That's the highest incidence of cardiovascular disease in the country. Now, California, as you see, is kind of a light blue. So you're down in the lower end. And those that have the white, like Colorado, have the lowest incidence. Unfortunately, everybody's moving towards the gray. And in our part of the world, in the southeast, we have at this point an 80% incidence of being overweight or obese. And that's driving a lot of the cardiovascular risk. And I'll show you how that works. We used to think that, if you have fat, it's just a bunch of lard hanging around and it's going to do something, just weighs you down. It turns out that fat's a very nasty organ. It's an endocrine organ, and it makes about 40 things that harm you. And I'll show you some of those later. So let's look at the big picture first. The traditional evaluation you have when you go into a physician's office is ideas about prevention, and the treatment strategies are related to what we call the top 5 risk factors for heart disease. And even though you may be treated what would be considered optimally for those 5 risk factors, there's still what's called a coronary heart disease gap. And what that means is that half of you in this audience, if I did the perfect treatment based on our present definition of optimal therapy for those top risk factors, half of you would still have a heart attack. Now, that should be a pretty clear message. We're not doing anything right when half the population are still having heart attacks despite what we consider traditional therapies. So what we've got to begin to do is look at what is it we're missing in the top 5 risk factors? What are we not treating correctly? But then expand it to something even more definitive, which is what is it we're missing completely that we're not measuring? What are the other 395 risk factors that no one's even measuring and therefore not even treating? So we have reached a limit in our ability to reduce cardiovascular disease based on our present medical treatments. We are a pharmacologically driven country. We are not a preventative medicine country. If you have an acute illness, if you have a heart attack or a stroke, there's no better place to be than this country, because you go to an emergency room and you can get your clot busters and you can get in the hospital and get your bypass or whatever, and you will probably survive as opposed to any other place in the world. But if you're talking about preventing the heart attack, we are the worst. We spend more money per capita than any country in the world and have the worst outcomes. So if something's got to change, economically, we're going to go bankrupt just from the healthcare cost. So what I'm going to do today is show you what the top 5 risk factors are, what we're missing even in those. Then we'll look at the 395 in more of a broad picture. I'm not going to discuss 395, so don't get up and leave yet. And then we'll give you some ideas about what you really need to know as a consumer to take care of yourself now. What can you begin today that prevents heart disease? And if nobody else is going to help you with it, at least you'll have the knowledge to do it yourself. So the traditional risk factor approach, which is the top 5, so let's just review what the top 5 are. High blood pressure or hypertension, dyslipidemia, that is bad cholesterol problems, high blood sugar and all the things related to that. We call it metabolic syndrome, type 1 diabetes, or type 2 diabetes, obesity, and smoking. So those are the top 5. All of those are clearly risk factors, and if you don't treat them, you're going to have a higher risk of heart attack. But in this country, what's kind of taken over the news media? What's taken over the pharmacologic media? What's taken over your doctor's office? We hear it every day, 15 times a day if you watch television. Statin, cholesterol, get your cholesterol down. I mean, the commercials regarding statins and cholesterol are almost as bad as the ones regarding erectile dysfunction. So the cholesterol-centric idea of reducing heart disease is really misleading. And I'll show you some data in a few minutes that if you look at your cholesterol level and you treat it with a statin, 50 to 75% of you still have a heart attack. So, obviously that one's not correct either. We've got to learn how to measure the risk factors correctly and also how to treat them. So here is the big picture. If you have all these insults out there in your environment floating around. And there's infinite numbers of insults. You can pick anything you want to. Pollution in the air, bad water, pesticides in your food, organocides, or any of these risk factors, heavy metal toxicity. Pick anything you want. That's an insult. Those are infinite. Those infinite insults attack your artery. Your blood vessel then says, okay, I'm going to do what I'm supposed to do. I'm going to defend myself from this insult. So it mounts a defensive attack against the insult. There's only three things your blood vessel can do. Three things, that's it. It gets inflamed. It gets what's called oxidative stress, which simply means that the cell, when it's under stress and it's damaged, releases things into the blood that cause damage to the rest of your body. You remember the old video game Pac-Man? Well, when you release these oxidative stress molecules into your blood, they're like Pac-Man. They go around everywhere and chewing up your DNA. They chew up all your organs, your cells, and everything becomes dysfunctional and dies. That's oxidative stress. And the third one is immune dysfunction. And you all understand immune function, meaning you get a respiratory infection, or a cold or pneumonia, your body gives an immune response and makes cells and antibodies to kill the bacteria. That's a normal reaction. So all these things are normal reactions. This is not an abnormal thing. Your body is very smart. It has a very high IQ and decides, this is what I need to do to defend your arteries from the invading insult, whatever it happens to be. I can only do three things, though. And I'm going to do them really well. And when I do it acutely, that's good, because you get rid of the offending insult. But let's suppose that your body says, you keep giving me insults. Every time you eat a McDonald's hamburger, you're insulting my arteries. Every time you smoke a cigarette, I really don't like that. Every time I go to the dentist, he says I have periodontal infections and I should get them cleaned up, but I haven't done it in the last 10 years. But I got all these bacteria in my mouth that are just constantly going in my arteries. That's an insult. What does your body do with that? It keeps doing the same thing. Now it becomes a dysregulated response. In other words, if you keep insulting me, I'm going to keep doing the same thing, but that's going to lead to a dysregulation, a maladaptation in your arteries that becomes a disease in and of itself. And what's the disease? Inflammation of your arteries, chronic oxidative stress in your arteries, chronic immune dysfunction in your arteries. So the body is doing what it's supposed to do. It is correctly responding to the insult, but later becomes maladaptive because you keep doing something that insults your arteries. So you got to remove the insults. And then you have to get those three things under control. Now there's a very important part of your blood vessel. I'll show you a picture. It's called the endothelium. Have you ever heard of the endothelium? Okay. It's the lining. It separates the blood from everything in the artery. It's very thin. It's one layer cell thick. And if you damage that endothelium, it's going to respond in one of those three ways. So if you have endothelial dysfunction, or ED, this is not the other time, this is the real ED of the blood vessel. By the way, there is an association now. Actually, very important. If a male goes to his doctor and says, I have erectile dysfunction, he's guaranteed to have endothelial dysfunction. Bad arteries. Because the blood supply into the penis is exactly the same blood supply elsewhere. And if it's not healthy, you have ED. So we have a saying in medicine called ED equals ED. That's very true. So this is your artery. I've taken it and I've cut it in half, and I've made a cross section. So you'll see a lumen. That's where your blood is. So your white cells, your red cells, your platelets are floating around in there. And right below that, you see what's called the intima, and that is the endothelium. That's that very thin lining. And that separates the blood from the area right below it, which is the muscle in the arteries, or the media. So, very simply, let's say that a white cell sees an invading organism, bacteria, and that's the insult. So what it does, it tries to eat the bacteria. It does something, and then it deposits on the endothelium. It's sort of a byproduct of what it's trying to do. It causes a little damage, puts a little hole in it, and all of a sudden the white cell decides it's going to go down through the hole, goes down into that muscle there, and it starts to form an inflammatory process. I'm going to show you how this works, but what I want you to understand is that this very thin layer is basically your fort. That's your protective layer. And when it's damaged or gets holes in it, it doesn't work. Now this is sort of taking the artery in another way, just kind of looking at it cross-section. I'm just going to walk over here so we can kind of see this. So here will be your endothelium, and that's this very thin layer. You have a little supportive tissue under that, and this is the muscle. So all the blood's out here. And if things start to stick here, and you can see there's little lines across here. These are where the cells stick together. And, if they start to do this, they pull apart and you form a hole, then things can slip through. So we want our cells to be sticky together. Used to play this game in school, holding hands if you can run through the arms. That's what you don't want any holes in this. So tight junctions or tight gap junctions are very important. Keep your endothelium very, very healthy to avoid unwanted material slipping down into the muscle. This is what your endothelium looks like under an electron microscope. On the left is normal endothelium. On the right is what happens when it becomes dysfunctional. So what do you see? All the cells are messed up. They're not nice and linear. So two things happen. Very important. First is you lose the function of that cell layer. So it's now dysfunctional. Thus the name endothelial dysfunction. But also it changes its structure. It's not the same. So if you had a burn on your arm, you lose the function and the structure. Same thing happens in your arteries. And once it happens, it starts sending out the wrong kinds of messages. Now this is a very big part of your body. The vascular endothelium is the largest organ, the largest endocrine organ in your entire body. It's 14,000 square feet. That's 6.5 tennis courts of surface area. It's 5 times your heart in actual mass. It's huge. So you can imagine if you've got that much endothelium in your body and it gets inflamed, you're not going to feel very well. And you're going to have some problems. So the next concept is what we call continuum of risk. So you go into your physician's office and your blood pressure is 140 over 90. It needs to be 120 over 80. It's so borderline, I'm not sure we need to do anything about it. Well, at 140 over 90 versus 120 over 80, you're already at increased risk for having something happen. Because every 1 point that your blood pressure goes up, there's an increasing risk for heart attack and stroke. It's a continuum of risk. There's no cutoff point. It doesn't, you get to 125 over 88 and then you're out of the woods. That's not that way it works. It's a continuum of risk going up and going down. And that's true for everything. It's true for your bad cholesterol. It's true for your blood sugar. It's true for how many cigarettes you smoke. It's true for your weight and your fat tissue. Now, all of these risk factors that we've talked about do something to your artery. That's the endothelial dysfunction. And the response to that is it makes things called mediators. And these mediators are like secondary messengers. You phone into the air traffic control system, and he says, "Okay, you got a flat tire. You can't land on the runway." And then he goes out and sends out the fire trucks and everything else. That's a secondary event going out there. So secondary messengers or mediators are the things that are going to carry out the three finite responses we talked about: inflammation, oxidative stress, and immune dysfunction. Now, there's another concept called environmental genetic interaction. And what that means is, we'll use food as an example here because it's easy. If your micronutrients or your macronutrients or your food, your fats, your proteins, your carbohydrates, or whatever else you're consuming is your environment of the day, you are individually programmed to respond to those nutrients differently than everyone else in the room. And your genetics determine how you respond. So that environmental or nutrient genetic interaction is the key to disease. So when you say, well, my parents had, this disease and that disease, yeah, chances are you'll have it too. So you have to be careful with how you interact with your environment. So that's why you see people, well, he's a farmer, he worked every day, he smoked 5 packs of cigarettes, he ate all this fat, lived to be 112. Well, maybe he had really good genes. But if he hadn't done all that stuff, he might have made it to 150. So you got to be reasonable about the anecdotal stories because your genes are responsible for how you respond to your genetics. And this is going to be a totally new concept in medicine called personalized medicine. When you come in, probably within the next few years, we're going to check your genes, not your Levi's, your regulars, and see what they are. And then we'll be able to determine not just what nutrients you should eat and not eat, but even if we decide to give you a drug, which ones are best for you. What your risk is for having Alzheimer's or a heart attack or kidney failure or diabetes or cancer. We'll be able to tell you based on your genetic profile. You can do it through a swab in the mouth. You can do it through blood tests. These are available now. We've got the genotype already done. We know how to do it. So we're going to start doing it. So the nutrient-gene interaction can go one of two ways. The beneficial outcome or the detrimental outcome. Good genes, good environment, good results. Bad gene, bad environment, really bad results. And the other two are in the middle. So here's the next question. You're dealt your genetics. You have control, for the most part, not always, over your environment. Does that interaction always damage your arteries? Not necessarily, because it depends on the interaction. What is the message going back and forth? So just because you have a whole host of risk factors doesn't necessarily mean that your arteries are going to become inflamed or diseased. On the other hand, let's suppose you have no identifiable risk factors. Does that mean that you're not going to get heart problems? Absolutely not. So this is what we call translational medicine. Translational medicine means, do your risk factors, or your lack of risk factors, translate into vascular problems? So if I just assumed that I measured your risk factors and you don't have any, but I don't do a test to see if your arteries are healthy, I'm making some big assumptions, and vice versa. So we have tests that will actually measure non-invasively your arterial health now. 2 minutes. In 2 minutes, I can tell you the risk of a heart attack or a stroke in the future. I can tell you how old you are based on your blood vessels. And here's what gets your attention. The lady comes in the office, she's 40, and I do this test on her, and I said, your tests show that you're 70. And she says, oh no, I don't want to be 70. What do I need to do? So immediately everything switches. She wants to change her whole life to get back to her actual age. Because the biological age and the chronological age don't always match up. And when you do a test that says you're older than you are, you want to do something about it. So a man is as old as his blood vessels. That was Sir William Osler. And in 1845, a German pathologist named Rudolf Karl Virchow determined, based on his analysis under a regular microscope, that atherosclerosis was a disease of inflammation of the blood vessel. And it took us 150 years later to figure out that he was correct. So atherosclerosis is a reaction to injury and inflammation within the arterial wall. That's his quote, which is exactly what I just said to you in 2012. Now let's look at a very fun little comic strip here of what happens with the bad LDL cholesterol. Now, a lot of people want to know, how do you remember LDL versus HDL versus VLDL? I mean, these crazy names. LDL is lousy density. Okay? You don't want these. But there's different kinds. See, if you look at that, what do you notice? They're different sizes, aren't they? Now, if you were just a logical person, you said, if I have these are endothelial cells, by the way, they're going across the top here. If I have really tight junctions here, nothing's probably going to get through most of the time. But what if they pull apart a little bit? Which of those LDLs is most likely to slip through the cracks? Yeah, the small ones, exactly. All right, so you're already catching on here that, if I'm going to have LDL, I don't want the small ones to do it, because they're going to slip through. I'd rather have the bigger ones. They're probably not as bad for me as the small ones. So here's what happens. You have a white cell. This one's a monocyte. We have different kinds of white cells. This is the monocyte. It's the one that is involved in the immune reactions and the inflammation. So there's a little crack there, damaged endothelium. White cell slips through. Oh, now the dense LDL comes through because we got holes. So the macrophage in the body say, you're not supposed to be here. So you're going to defend against the small LDL particles. The LDL changes, it becomes modified. And it can become oxidized, that's the oxidative stress. It can become what's called glycated, which means that if you have a high blood sugar, it changes the formation of the LDL because the glucose changes it. So diabetics really have a lot of these small particles that get modified. So dense LDL is very quickly modified into a type of LDL that is a foreign particle. It's an enemy. The macrophage defends against it by doing what? What's it doing there? It's eating it. It's eating the LDL cholesterol because if it gets it inside the macrophage, it is protecting it from the rest of the body. So the ingestion of those small LDL particles can, over time, reduce the atherosclerotic process. Unless what happens? You keep insulting your arteries. You get more and more LDL. Eventually the macrophages can't do much. So they do what? They get bigger and fatter, and they form what are called foam cells. And the foam cells start to stick together, and they form fatty streaks and plaque. Now you'll notice that all this stuff is going on below the endothelium, right? Let's look at this. It's very important. Here's the blood out here. There's your endothelial lining. There's nothing out here in the blood. You don't have any plaques sticking out here, do you? Where is it? It's all here. It's in the what's called the subintimal layer, the subendothelial layer. Okay? So let's say this gentleman right here has chest pain, really bad. He goes to USF, goes to the emergency room. He gets an arteriogram. Come back and say, arteries are clean. There's absolutely no blockage, no plaque. You have the arteries of a 16-year-old. Go home. 2 years later, he has a heart attack. Why? Because when you do an arteriogram, you measure what is out here in the lumen. You don't see any of this down here. So if he had a huge plaque right here that's growing and he doesn't do anything about it, 2 years later, let's see what happens. It pops. The big plaque continues to get so huge that it goes right through the endothelium and it ruptures into the artery. Releasing what? All that stuff that's been accumulating for decades. LDL, white cell particles, inflammatory cytokines, all this nasty stuff erodes into the artery and then it clots. Because when you put that in your artery, thrombosis and clotting occurs right over the plaque, and you get 100% blockage in the artery and you have a major heart attack. So when you have an arteriogram done, it doesn't mean you don't have heart disease. There are tests we can do to see the plaque now, and I'm going to show you some pictures of how you do that. Some of it's invasive, some of it's not invasive. Now, within the system, we have the cleanup crew, HDL. Let me give you an example of how this works. How many of you play tennis? Okay. When you play tennis, will the tennis ball go through the net? No, unless they're holding the net, right? Okay. Will a golf ball go through? Absolutely. So the golf ball is a small, dense LDL. The tennis ball is a big, fat LDL. Now, if you get a lot of golf balls on the other side, who cleans them up? Well, in the case of your arteries, it's your HDL cholesterol. So HDL is the cleanup crew. LDL is the garbage. If you were the cleanup crew, would you like to have a big garbage truck or a small one? I like to make one trip, big garbage truck, get it out. Okay? So you want big fat HDL. You want the big HDL to go in and clean up all the garbage made by the small LDL. So we have different sizes of those. And you can see these. The best one to have is called HDL2. It's the big one. 2B, and it's the one that goes in and cleans up the mess. Okay, so what we're trying to do is balance your injury versus your repair. Quote from Hamlet, Shakespeare. The heartache and the 1,000 natural shocks the flesh is heir to. Meaning, the blood vessels has a finite number of responses to an infinite number of insults. Even Shakespeare figured it out. Okay. Now, metabolic memory, another concept. Your body responds immediately to the insult, but it remembers what it did. Just like you remember what happened to you a week before. And so the second time it happens, it doesn't have to figure it out again. It immediately responds. It not only responds faster, it responds more aggressively. Hyperimmune response. And if you remove the offending insult, there takes a time for things to cool down because the body remembers. So even a tiny insult, okay, I'm eating 12 McDonald's hamburgers a day, I'm going to cut down to 1. Your metabolic memory is going to say, yeah, you've done a pretty good job, but I'm still going to have a hyperimmune response to the 1. You've got to eliminate it because it takes a while to crank down the immune response and the autoinflammation. So there's your 3 final responses. Just to remind you, oxidative stress, inflammation, and immune responses. And it's your genetics. But there's also another term you may have heard called epigenetics. Epigenetics means out of or above genetics. This is really scary stuff. For example, if a mother eats the wrong kinds of food during her pregnancy, it affects the fetus epigenetically, not genetically. So she has a fat child, and the child stays fat. Because the epigenetics are misinformed about what's going on. Same thing happens with starvation. It also can precipitate diabetes. So there's a lot of things that happen that we are exposed to that are going to be carried on in generation after generation. It has nothing to do with your genes. It's your exposure as an adult that you hand down to your children. You then hand down to your grandchildren. So look, this is a very important, a little complicated slide, but it kind of sums up what we've talked about. Yeah. So here are the infinite insults, right? So we have biomechanical and biochemical. So the biomechanical is everything you think of, you know. You've got what you eat, bacteria, viruses, dead cells in your body, heavy metals, whatever. And you have biomechanical, which is your blood pressure and your blood flow and all that stuff. So all these insults attack your artery right here. And they attack different kinds of receptors. The endothelium responds, and it does these three finite responses, and those result in endothelial dysfunction and a heart attack. That's kind of the whole story in a nutshell. So what we want to do is get rid of the insults. We also want to try to backtrack if we have one of those finite responses and get rid of that inflammation and say, why are you inflamed? Let's backtrack up the list and say, what is it that's doing it? We're going to ask the why. So we have microbes, that's bacteria, viruses. We have sterile antigens, that's all the dead cells floating around. And we have your nutrients. And those things attack these receptors, and they result in oxidative stress, inflammation, immune responses. Now, there's a very fancy name for these receptors. Pattern recognition receptors. Now, that's pretty cool, because think about it. Your body has figured this out. It says, you know, there's a pattern here, and you keep repeating the same pattern. So I'm going to keep responding the same way. So those pattern recognition receptors are an absolute necessity for determining those downstream responses. And I'm going to show you some things on how you can alter your PRRs, how you can tone them down with nutrients and foods and supplements. And here they are. You might want to write these down as things you can start doing immediately that inhibit that PRR interaction that tones down the finite responses. You're all familiar with curcumin or turmeric, cinnamon, broccoli, resveratrol, red wine, grapes, green tea. Look at the list for lutein. Celery, green peppers, rosemary, carrots, oregano, oranges, olives, and quercetin. Tea, apples, onion, tomatoes, capers. So here's what this really says. A lot of vegetables, a lot of colors, a lot of good fruit, a lot of spices. Organic, in my opinion, is very important. I know it's expensive, but let me tell you, if you knew it was in our food supply and our water supply, you'd be scared to death. And I know, unfortunately. So I'm scared. So you should be too. Yeah, pesticides, organocides, hormones. Oh. So everybody got the list of things? Everybody got the list? Okay. All right, so there's our biomechanical, biohumoral responses. You've learned insult, response to PRRs, three finite responses. Okay. So atherosclerosis is a post-meal disease. Every time you eat, you inflame your arteries. Now, you'll inflame them worse if you put the wrong kinds of inflammatory foods in. But when your blood sugar goes up or your triglycerides go up, every time you eat, you have what's called endotoxemia. You remember when women were using tampons and endotoxic shock? Remember that? That was some staph, some bad bacteria. So endotoxemia is a bad infection. So when you eat, you carry not only the bad nutrients across, you carry bacteria across as well. That's the endotoxemia. Did you remember what happens? That's the metabolic memory. So there's some things, there's a lot of things you can do to block the response. It's the same thing. Rates, different types of fats, causes endotoxin, bacterial products, and all that stuff. So there's some things, there's a lot of things you can do to block the response. It's the same thing. Fruits, vegetables, right types of fats. Get the trans fats out. Okay? You use a lot of omega-3s, a lot of monounsaturated, like olive oil products, and get rid of the bad fats and refined carbs. That's kind of the bottom line here. This disease starts in utero. So by the time you are in your teenage years, you've already got vascular disease. We figured this out when we had, soldiers that were dying in different wars at autopsy. They had significant heart disease coming back. So it starts like this, and it progresses down. I've kind of showed you the progression from endothelial dysfunction down to this big subintimal plaque that ruptures. And here's the scary thing. 50 to 75% of patients hospitalized with an acute heart attack have normal cholesterol levels as defined by our present standards. And up to 50% of those who have a heart attack have none of the top 5 risk factors at all. Now, this is what's called an intravascular ultrasound. Our gentleman over here that went to the UCSF's emergency room has the arteriogram on the left. Okay? It's normal. See, there's no blockage. None. Zero. All these arteries are totally clear. All this white stuff is the dye in his arteries. Okay? So now we're going to take this artery where the arrow is, and we're going to put a probe inside the artery. We'll put an ultrasound in there. We're going to really see what's going on. And that's what this is. So now we have a probe. This is the inside of the artery. See all this white stuff? That's plaque. That's what they didn't see. That's what I showed you earlier. 2 years later, that's what ruptures into the arterial wall. And you have your first big heart attack. Okay, by the time you're 13, 17% of people have arteries that look like that. By the time you're 40, 60%. That's in this country. And this is what a plaque looks like. And basically, you've heard of a good plaque, bad plaque, or hard plaque, soft plaque. This is the kind of plaque you don't want that actually has a lot of stuff in it, and it literally eats through the wall. That's what's called a soft or unstable plaque. When they get real hard and calcified, they're not as likely to rupture. So there's 400 risk factors we're trying to talk about. We've talked about the concepts in the book that I've written. I've commented on all these things which you can look at. But what I want to leave you with is a couple of very important things. When you're checking your blood pressure, it's not just your office pressure anymore. It's not just your home blood pressure. What you really want to measure is your 24-hour blood pressure. What's it doing at night? How quickly does it increase in the morning? How labile is it during the day? So the new standard of care for hypertension is 24-hour blood pressure monitoring. Okay? If you're a dipper, meaning your blood pressure drops at night, that's good. If you're not dipping enough, that's bad. If you dip too much, that's bad. You have to dip just the right amount. We talked about the different particle sizes. We can measure those by advanced lipid testing. And you've learned which particles are good and which are bad. This is a nuclear magnetic resonance example showing you all the things floating in your blood. The big ones and the little ones. Okay. So if I measure your particle size and number, and I say, well, your LDL is 100, you now know that the small ones are the worst. Advanced lipid profiling is the best. So when you go to your doctor, you don't want a routine lipid profile anymore. You want an advanced lipid profile that measures the particle sizes and the particle numbers. So that's your lipid story. So blood pressure, 24 ABM. Lipids, advanced lipid testing. And remember that when you get your blood sugar checked, what's really normal? Fasting is not 99, it's 80. For every point you go from 80 up to 100, your risk for a heart attack goes up by 1% for each 1 point. So if you're at 99, you're already 25% or 20% over risk for a heart attack. Watch your midsection. There's about, like I said, 40 different things that cause vascular problems that are in your fat tissue. It also occurs around your heart. And we can measure the fat around your heart, which correlates with the same risk as the fat around your belly. And please, don't smoke. And these are tests we can do. I'm going to just show you some real quick pictures, then I will end. These are the non-invasive tests we have available to identify early vascular and heart disease. We can do your carotid arteries. It's an ultrasound. We can do an echo of your heart, which is an ultrasound. That's what it looks like. Very fancy, measures your valve function, your muscle function. We can do all kinds of fancy things to correlate it. We can do CT scans, electron beam tomography, looking at the plaque and the calcification. We can do these fancy CT scans to look at the arteries non-invasively, see if there's plaque. We can measure your arteries, seeing how healthy they are, your biological age, your chronological age, and predict your risk for heart disease in the future. Very simple. And you can do very fancy lab testing now, looking at all these different risk factors. And we'll talk about those we'll talk about in the book. And then finally is basically your program, which is good nutrition, losing weight, exercising, don't smoke, and getting a lot of sleep. 8 hours a day actually is perfect. Jog your mind. 8 hours of sleep. And then there's some supplements and vitamins and minerals, antioxidant things that are helpful. So I'm going to stop there. Caloric restriction, heart disease, very important. Caloric restriction made simple. Here's what you do. Okay? Every caloric restriction should be easy. Don't eat after 6 p.m. at night for 4 days a week. So a 12-hour fast. Okay? And if you do that one thing, you'll simulate some of the clinical studies of caloric restriction. So it's not so much the calories per se, it's the 12-hour fast. But in essence, what you want to do is get about a 25% caloric restriction overall. But do 12.5 on your calorie side and 12.5 on your exercise side. That's 25%. And then the rest of it's a 12-hour fast overnight. So if your HDL is a bit high, but HDL is really high, what? Very interesting question. A high HDL over 85 is actually probably not a good thing to have because it means you're inflamed and your body's trying to protect itself. So we have to measure the particle sizes and numbers, but something I didn't have time to get into is just because it's there doesn't mean it's working. Is it dysfunctional? So that's a problem. Does taking calcium supplements affect arterial plaque? It's probably more the vitamin D than the calcium. So be sure you have your vitamin D checked. If it's low, get it corrected, and you don't have to worry. Are there things you can do to clean out the arteries? Yes. I'll give you 4 things that are natural. Okay. Vitamin K2, MK7. K2, MK, it's a form of vitamin K. Aged garlic. Omega-3 fatty acids. And then there's a couple of drugs like ACE inhibitors and ARBs. Stress is a major heart problem. Can you discuss its features? The main problem with stress is it increases cortisol and adrenaline levels, activates the immune system, and causes high blood sugar and other issues that affects the other risk factors. So, in effect, any type of stress, anxiety, or chronic depression is bad for your heart. Acupuncture is great for a lot of things. No data on increasing HDL that I'm aware of, directly at least. What are the destructive effects of prolonged anesthetic? Oh, they're terrible. It's a fat-soluble thing. It gets in your liver and your fat tissue, and it's reabsorbed and it's kind of released over time. It affects your brain. Japan will talk about this, your heart, and other organs. A lot of surgeries are not good for you. Dry mouth and throat during bedtime. Usually dry mouth is due to a drug or a disease called Sjogren's syndrome. And the best way to treat that is to humidify your room or get some artificial things you can put in your mouth like sunlight. And the last one is what test do you use in your office to measure the vascular age? Measure vascular age. It's called an endopat. E-N-D-O-P-A-T. Endopat.